You walk into your patient's room, clipboard in hand, ready to perform your routine morning assessment. You greet your patient, check their vitals, and begin your head-to-toe evaluation. Everything seems stable until they shift uncomfortably and catch your attention.
It's back again, nurse. That awful burning feeling right here, right after I had my breakfast. It feels like my food is coming back up. What is this? It's really starting to worry me.
They look anxious as they point directly to the sternum. This is a classic presentation, a scene you will encounter countless times in your nursing career. Your clinical judgment must activate immediately. While it might be simple indigestion, it could also be gastroesophageal reflux disease or GERD. But before you even consider that diagnosis, your number one priority is patient safety. Chest pain is always treated as a potential cardiac event until proven otherwise. This is a critical thinking checkpoint and a high-yield NCLEX concept. Your first action must be to rule out a life-threatening cardiac issue. This means obtaining a 12-lead ECG and a full set of vital signs, assessing for other cardiac symptoms like radiating pain, shortness of breath, or diaphoresis. As a professional nurse, you must act swiftly and with purpose. Once a cardiac event is ruled out, you can pivot your assessment toward GERD. So, what exactly is happening inside the body? GERD occurs when stomach acid, a powerful digestive fluid, frequently flows back into the tube connecting your mouth and stomach, the esophagus. This backwash, or acid reflux, irritates the delicate lining of the esophagus. Think of the lower esophageal sphincter, or LES, as a one-way door. It's a muscular ring that's supposed to open to let food into the stomach and then snap shut to keep stomach contents from coming back up. In GERD, this sphincter weakens, relaxes when it shouldn't, or is otherwise dysfunctional. This allows corrosive gastric acid and pepsin to reflux into the esophagus, causing that signature burning sensation known as heartburn or pyrosis. But GERD is more than just discomfort. If left unmanaged, chronic reflux can lead to serious complications. It can impair breathing, disrupt sleep, affect nutrition, and even delay wound healing due to the systemic stress it causes. Your role extends far beyond just providing comfort. It's about critically assessing the situation, implementing the correct nursing actions, and providing crucial patient education to prevent complications and improve quality of life. Mastering the nursing care for GERD is essential for both exam success and for providing safe, effective care at the bedside. In this video, we'll break it all down for you, from pathophysiology and risk factors to the key nursing interventions, pharmacology, and NCLEX-style questions you need to know. Let's get started. Begin with active listening and targeted questioning. When does the burning occur? Is it related to meals or specific foods? Does it worsen lying down or bending over? Quantify severity and clarify quality. Burning, sharp or dull. Prioritize a focused cardiac and respiratory assessment. Listen for irregular heart sounds. Check for crackles or wheeze. Possible aspiration. This is a crucial safety step. Assess nutritional status, weight and any changes. Inspect for acid-related tooth erosion. Review meds, note agents that relax the LES. Alarm signs, unintentional weight loss, persistent vomiting, hematemesis, melena, progressive dysphagia. Diagnosis is confirmed through history, PPI trial, EGD, 24-hour pH monitoring or barium swallow. Your role, education, NPO verification and post-procedure surveillance. Welcome to Section 4, where we apply our knowledge to nursing care for GERD. When creating a care plan, we focus on several key nursing diagnoses that address the patient's most pressing problems and risks. Our top priorities are managing acute pain, preventing risk for aspiration, correcting imbalanced nutrition, and addressing the universal knowledge deficit. Each of these guides our interventions and patient education. For acute pain, we must first address the primary complaint of heartburn and chest discomfort. A critical first step, especially for an NCLEX scenario, is to perform a focused cardiac and respiratory assessment and obtain a 12-lead ECG to rule out a cardiac event. Patient safety is paramount. Once cardiac causes are excluded, we use a two-pronged approach. Pharmacologic control of acid and soothing non-pharmacologic measures. This combination provides both immediate relief and long-term management of the painful symptoms. Next, risk for aspiration. The backflow of gastric contents into the throat is a major safety concern, especially when the patient is lying down. This reflux can silently enter the lungs, leading to serious issues. Potential complications are significant and include aspiration pneumonia, chronic cough, bronchospasm, and laryngitis. Monitoring respiratory status, including oxygen saturation and lung sounds, is essential. To protect the airway, positioning and prevention are key. This is an immediate and effective intervention you can provide at the bedside. Educate the patient to avoid eating for at least 3 hours before bedtime to reduce nocturnal reflux, and to elevate the head of their bed at home using blocks or a wedge pillow. For imbalanced nutrition, the pain and discomfort from eating can reduce intake, leading to unintentional weight loss and nutritional deficiencies. We teach patients to eat smaller, more frequent meals and to practice trigger avoidance. This means identifying and limiting foods that relax the lower esophageal sphincter, like chocolate and high-fat items, as well as direct irritants like spicy foods and citrus. Finally, knowledge deficit is nearly universal. We must empower patients with clear, actionable teaching to manage their condition effectively. Explain the pathophysiology of GERD, the purpose and correct timing of their medications, and the crucial lifestyle changes needed for long-term control. In terms of immediate care, positioning is vital. The head of the bed should be elevated 30 to 45 degrees to use gravity to help keep stomach acid down. If a patient shows signs of severe respiratory distress, such as choking or cyanosis, apply oxygen, ensure a patent airway, and call the rapid response team immediately. Pharmacologically, antacids offer quick relief for mild symptoms. H2 blockers like cimetidine reduce acid production, but the first-line therapy is proton pump inhibitors or PPIs like omeprazole. They are most effective when taken before the first meal of the day to strongly suppress acid production. Now let's discuss the serious complications that can arise if GERD is left unchecked. Chronic exposure to stomach acid can lead to esophagitis, which is inflammation that can cause bleeding and painful ulcers in the esophageal lining. Over time, this repeated damage and healing can lead to the formation of scar tissue, creating esophageal strictures. These narrow the esophagus, making swallowing difficult and painful, a condition known as dysphagia. One of the most critical complications is Barrett's esophagus. This is a precancerous condition where the normal esophageal lining is replaced by tissue similar to the intestinal lining. This significantly increases the risk for esophageal adenocarcinoma and requires regular surveillance endoscopies to monitor for cancerous changes. Remember to think holistically. The effects of GERD aren't confined to the esophagus. Acid can be aspirated into the respiratory system, causing a chronic cough, laryngitis, and even triggering asthma attacks or leading to pneumonia. It can also cause significant dental erosion. Patient education is a cornerstone of GERD management. Start with simple, impactful rules. Eat small, frequent meals to avoid overfilling the stomach, and stop all food intake at least 3 hours before bedtime to allow for gastric emptying. Counsel patients to limit common triggers that relax the lower esophageal sphincter, like fatty foods, chocolate, and peppermint. They should also avoid direct irritants like spicy foods, citrus, and carbonated beverages, which can increase gastric pressure. Lifestyle modifications are key. Advise patients to remain upright for at least 2 hours after meals. Elevate the head of the bed on 6 to 8 inch blocks, not just with pillows. Emphasize the importance of smoking cessation and pursuing healthy, sustainable weight loss, as both significantly impact GERD symptoms. For severe, complicated cases unresponsive to other treatments, surgery may be an option. The most common procedure is the laparoscopic Nissen fundoplication, where the top of the stomach is wrapped around the lower esophagus to reinforce the sphincter and prevent reflux. Now, let's apply this to the NCLEX and your clinical practice. When a patient presents with chest pain, follow a simple but critical checklist. First and foremost, your priority is safety. You must rule out a life-threatening cardiac event. Second, screen for alarm signs like dysphagia, odeinophagia, hematemesis, or melena, which indicate serious complications. Third, implement immediate comfort and safety measures like elevating the head of the bed. Fourth, administer prescribed medications like PPIs or H2 blockers and teach the patient their purpose and correct timing. And fifth, provide that crucial counseling on diet and lifestyle modifications. Always remember to document all your assessments, interventions, and the education you provided. So, for your NCLEX question, a patient reports severe squeezing retrosternal chest pain after a large meal. Which action should the nurse take first? The correct answer is to obtain a 12-lead ECG. Even with classic GERD symptoms, you must always rule out a cardiac event first. Patient safety is always the top priority.